Well, thanks everybody for bearing with us. We'll get started. And actually, well, I'm supposed to remind everybody we are recording this meeting, so that has already started. And we do have a hard stop at 3 o'clock today. I have to get on a train to go home.
That's important.
Yes. So I'm gonna largely, John, if it's okay, for the recap of the last meeting. I wasn't present. Were you?
Okay, I was present, but I didn't care recap.
That's okay. I don't think we necessarily, I think last time, the way I understand it, largely we were talking about the recommendations, and I think we're at the tail end of these discussions. So really trying to wrap up for the purposes of the report that will be submitted. And I think the goal today is to dig further into those recommendations and start.
That was very much the thought that, I don't know if concern is the right word, but coming out of the meeting is going to be a report with recommendations, and I know the task force wanted to see them in writing, right? Because they've been in the notes and pieces here and there, but to be able to really endorse them, I think the task force felt they needed to review them basically one at a time in writing, and as well as so wordsmithing them, and then there's other things that we probably talked about that didn't land on the recommendation. So it's not really to say what's missing.
So if that makes sense, I think we'll dive into the first recommendation and go from there. Okay. All right. I will read it out loud. This is just everybody remember it's draft, and we'll wordsmith this as we go through. But the recommendation is to establish a system that provides referrals and access to support such as birth control and counseling, education about risks to substance-exposed infants, early intervention services, and home visitation in places where parents are receiving treatment and rehabilitation for substance use disorders. Services, particularly education, should be community-based. That is, information and services should be tailored to and provided by members of the community. In many places, there are multiple touch points in the community that the family could access voluntarily. For example, nurse-family partnerships, doula programs, mentoring programs, and community-based programs currently exist and can be tapped to co-locate with treatment and rehabilitation providers. How do we feel about this recommendation?
So this is addressing goal 2, I'm assuming.
Thank you. Right. Improving outcomes for pregnant and parenting women who are striving to recover from addiction. And what I like about this in particular is the emphasis on community-based, right? That there are services that are available that can be used for preventative purposes, but which I think helps with the long-term outcomes of, improving overall outcomes for pregnant and parenting women who are suffering from substance use disorder. So I personally really like that component of it.
I'm not sure I recall what we meant by establish a system. What would that look like? A system.
So that's very broad, but I think what I'm going to do is highlight, if you go into like what was the third line where we go to in places where parents are receiving treatment and rehabilitation for substance use disorders. So this isn't just some amorphous system that exists somewhere. This is in places where women are going, where parents are receiving treatment. That's where there would be, a system, and again, we can wordsmith it, but the system to provide access to referrals and services. So it's not just random. Maybe some offices do that well and some don't, right? And there's specific maybe documents they should be, phone numbers they should be giving out, resources, community education, pamphlets, things to read, videos to watch. Those are the things specific we'd be saying that places where parents are receiving treatment and rehabilitation services, there would be some specific education tools and resources.
Yeah, I like starting with that,
I do
so that
too,
it really
yeah.
focuses in, and then I can see that we say in these places, these are the resources that should be available. And I think that focuses it and streamlines it a little bit more.
And it says a system. I mean, depending on the place, you may need more than, and the system may, you may need more than one system, because depending upon where you are, system may work for one place, but it might need to be a little bit different for another place, so it's, I don't know whether it's sort of.
Yeah, it's almost like
It makes
established
like-
channels.
Yeah, it makes it sound like one system fits all, where
Yeah.
that's not necessarily gonna be the
Yeah, I think you're right.
case.
Yeah, I don't think it has to be necessarily a system. It needs to be in these places. Patients or clients should have access to these things. So however you do that, you can do it, but wherever they're seeking treatment, this is what should be also available to them.
Maybe it's establishing guidance and tools. Those are the things that have to be
Something like that,
procedures, right? Yeah, system is just a big word.
It is, and it comes with a big
And it's not-
connotation.
Not descriptive enough for what that would be, yeah.
And it's not one size fits all, because it depends upon the site.
Maybe if we had some kind of like universal protocols that if that you make sure you're making these resources available with your medical
These
center.
components.
Yeah, like a, almost a, or are we talking about actually embedding services, co-locating them?
So actually, I'm thinking
Not
we might, I'm sorry.
Oh, it's okay.
I was gonna, we might need to get one step more specific. Because the recommendations from this task force, like who would establish this? Who would, maybe the recommendation really is that a board is developed or another task force or future iteration of this task force would create this protocols or rules. Otherwise, it's nobody's job to do it.
Yeah. And that avenue would allow the task force work to, not the task force, but its intentions or its recommendations to actually have it a longer shelf life. If there were a body that helped set forth the recommendations, it could, Governor Rendell had a commission. You know, maybe we could recommend something like that, something to be developed that's multidisciplinary.
You can even go a step further to say that bodies should remain in place to monitor the outcomes of that work.
Fantastic.
Dr. Castello put in the chat about using the word framework instead of system. I don't know if you had already covered that. I just wondered.
No, I think that's right. I think that's what we were kind of wordsmithing was the system. So that's an important word there too. I mean, the way I read this, it's really bring resources and information available to people where they're seeking treatment, right? So to cross multiple systems, I would think the recommendation could be that our 3 departments work with the providers and other entities that we contract with to disseminate this information to try and close the loop on, like, I guess I'm not articulating this very well, but I think about somebody who's incarcerated, right? Medicaid can't pay for anything that happens when somebody is incarcerated from a healthcare standpoint, but they're gonna come directly into our system when they get discharged from that facility. And that's where you wanna break down the barriers to, just because you're here and you're seeing somebody for child welfare purposes, if you're a pregnant mom, they should also give you resources about, parenting supports and other things. So I think that's what we're
I
getting
think
at,
start with
right?
that concept, right? Like the first one should be like establish resources and supports in the places where people go and
Where they are, right?
And they look different and may even be incarcerated,
Which is
right?
Right, yeah.
Right.
But I think it is a good idea to recommend that there is some working group to implement the recommendations and monitor the outcomes. I think that probably should be overarching, but then I think you can say then in places where people are receiving treatment, this is the expectation of what they should have access to. And the task force, I think, would be the ones to work on kind of the nitty-gritty of how that actually plays out, but that would be the recommendation. But I think the task force idea is a good one so that we can make sure that these recommendations have an owner.
Typically takes ownership of cross-departmental efforts.
Just depends what the focus is and who has the bandwidth.
You touch
To
your
do
nose
it.
and watch what's happening.
Usually it doesn't come to me because I have the fewest number of staff people, but, yeah, it just depends on what the recommendation
curious.
is.
But I do think maybe something that says, representative of the Department of Services, or developed along with like community representative.
I was trying to think if there was already, like, we already all have so many committees and task forces and advisory
Yeah.
councils. I was trying to think, like, could we assign this to one of those?
Yeah.
But
I don't know
in my
who it
space,
is.
I don't have one that fits well, so.
And if the Office of Advocacy and Reform continues forward in the next administration, maybe within the Office of Child Advocate, there could be a working body so that it's inclusive of all three major departments that touch the population, but not necessarily housed within one.
Yeah, I think it's good, but I think, like this task force, you also need leadership from those agencies to be able to,
Yeah.
to implement the recommendations. I think that, staff kind of coming up with the nitty gritty of it, I think it's great, but you need to have, some leadership from your department to say that we will do
You
it.
are to the people doing the actual work and better the product is.
But I think a multi-agency, task force would be a good start.
Starting thoughts
Yeah,
about.
actually, I have one. I thought also in addition to that, that there would be, like, in terms of birth control, that it would be more than counseling. Somebody could go in and they say, oh, you're here, here is birth control if you need it. Like, there would be an actual product, or here is Narcan if you need it. So more than like guidelines, the intent of co-locating services was the actual providing of. So can that, I don't want to, say that my impression from this would include things like that. So somebody
have to be medically based. If you need a script for birth control. Your physician.
Or some sort of agency. It would be different based on the place you're talking about.
Right, the
building,
institution.
Because like there are SUD treatment facilities that have physicians on staff, so you wouldn't need to add a physician to it. You're just adding some work to what they'd be potentially prescribing or providing.
But yeah, I think the information would vary, or the products would vary that you would make available to people that the working group would recommend, right? That to your point, Dr. Johnson, about kind of doing the nitty gritty. So it wouldn't necessarily always be appropriate for somebody to have birth control on site. That would make sense for a medical office, but like a Narcan, I'm thinking about it as like a woman who walks into a police station who's pregnant. I'm making this up a bit, but we need to consider the whole person, right? So if she's there to deal with one legal issue, it's also, oh, hey, we noticed by seeing you that you're pregnant and it looks like you could use information about X, Y, and Z, or resources about X, Y, and Z. I guess the point I'm making there is I don't think it has to be a static set of, the guidelines that say you have to have all of this information available to each individual person. It's got to be fluid a
It
bit.
would probably evolve as you're learning, like, oh, we didn't think of that.
Right,
So we
right.
gotta start doing that, yeah. So why the monitoring is important, and maybe back to your point earlier, which is, that's probably an overarching thing we'll have to keep coming back to, which is the ongoing monitoring and implementation of these recommendations and the evaluation. Thing I kept doing when you were here was going, you got what you need, make sure you have what they needed to.
Okay, all right, well, moving on to recommendation number 2. Establish ways to connect parents to services and support, such as plans of safe care, without involving county children and youth systems.
I think if it helps to just say on behalf of the county children youth systems, we are in favor of that. Establishing ways to connect parents to services and supports. Again, that's a very broad, it's like saying systems, right? So I do think we have to maintain that Boarders should report when they suspect abuse, but a lot of these circumstances we're saying are outside of that. They're not suspected abuse, they're just trying to connect families to resources and supports, and in those cases. But when we say ways, my question for the task force is, I mean, we had talked about whether there should be a separate phone number or something like that outside of child line. Or is that where 211 or some other sort of resource line comes in to connect people? So I'll turn it over to the task force to say, how do you want to phrase that? Because we want to create so many pathways that it's confusing.
Yeah.
And we don't want, when people have an actual report of child abuse, them to report it to somebody other than child line.
Yeah, I think if you had a separate number, and I don't know logistically how that would work. I mean, ideally, there would be a number that people could call, and there would be people who are answering this number who had access to those resources that they can connect people to. So I don't know if that is already existing, or, I mean, if that group is existing, so you can just put a phone number to that group to do that, but I think in my mind, that's what you need. You need a, group of case management, to say, these are the services that you can access and connect people there. How, what we have already.
I think that's the vision behind 211. If you don't feel that that's,
You can use the Philly Families Can as an example. I was telling you guys that, and that's ran through the health department. But it does connect family to resources and an alternative line.
What's it called again?
Philly's Families Can.
Would these same resources that we're talking about in recommendation number 2, they would pretty much be the same resources that are available in number 1, right? So maybe we don't even, I mean, we could go so far as to establish a statewide number, but if we maybe just make it a, the way I look at it, recommendation number 1 is gonna be implemented, it's probably gonna be different county by county, basically, right? So, just within the county, just have, okay, so this is the number that you can call to, if there's not suspected child abuse or, anything like that, you can call them to plug them into these resources, and then if there is suspected child abuse or, that sort of thing, then you call child line, like it could still be run within that same set of supports as a number 1. I don't think we need to establish anything too crazy.
But I think the way I'm looking at it is, if a family is in crisis and they want to reach out themselves, and they're
Oh,
not
okay.
reaching out to child line, but
Okay.
they're
That's-
saying, I've got all these things going on, where do I turn for resources? Here's a number you can call, and they can connect you with resources. And I see this as a little bit more goal number 3 as opposed to goal number 2.
Okay.
This is really supporting the family and the children.
That makes sense. I'm coming at it from a provider perspective, not a family perspective, that makes sense.
Well, actually, John and I were down at the Philly DHS office a month or so ago, and they were talking about, they have a number of youth that are hoteling in the DHS municipal building downtown. And we were trying to understand, what does that look like? Are there any services that you're offering these kids? Not at all what it was depicted as in the Inquirer, but one of the things they talked about was the Philly DHS number that parents call is attaching like an advocate into it. So if you have a family who calls in the middle of the night and they're a therapeutic foster care family, they're saying like, hey, this situation is really out of control. This kid's either I'm going to kick them out or you're going to give me something that's going to help de-escalate this situation. That's kind of what I think of this as being really is that touch point for both families who need it, right? Want to call and ask for services themselves and don't want to call DHS because they worry that's going to immediately trigger child welfare involvement. So how do you make resources available for people in the times that they need it without penalizing them? I think is what we're getting at there.
Can I ask, maybe this is a silly question, who's sort of the target audience of these parents and families? Are we talking about parents and families impacted by substance use disorders specifically that are looking for help? Or are we talking like more broad than just families in crisis who need help. I mean, the vision of this task force was related specifically to opioid abuse, which I don't like that word, but that's another soapbox. So are we thinking of these recommendations in that kind of more narrow focus, in that we're trying to create resources for families and parents impacted by substance use specifically? Or were we thinking of kind of broadening? Because we do have a hotline that's already established and available for individuals and loved ones struggling with substance use disorder, and they're already trained to provide various resources and connectivity. And it wouldn't take much effort to expand their knowledge bank and their resource bank without creating an additional number. And that is separate and apart from Childline, and they could make referrals to Childline if, if that was appropriate. But that would only be appropriate to do if we're talking about this scope of people being related to kind of the substance use disorder world.
I think it's a great point, because you don't want to have a committee scope creep where you go beyond your. So I would say if we can't take a recommendation and have a line of sight to one of the 4 bullet points that we're supposed to be working on, then it probably shouldn't be a recommendation. And so if it helps get us closer to one of those goals.
Yeah, I think that's a great point. I was thinking really broadly, but if there is a number already, then part of the process would be when you're discharging someone, when you're treating someone, make sure that they have this number so that they can get resources. And so that, yes, we don't have to create something else. That's already in there, but it should be systematic so that if you're getting treated, then you have access. You have access to that number so that you can get those services.
How would this be separate from what we do with establishing plans of safe care? That's what I'm just thinking. If you're in a hospital and you've got a social worker who thinks we need this and they're putting this in. So I'm wondering how would it be including that? Would it be separate from that? Because that's where it might get a little tricky.
I think you still could have this plans of safe care, but you should also get this number. And for those people who are just getting treated and they don't have a newborn and they don't have a plan of safe care, then they are also getting this number. So any people with families, if they're going to a treatment center, here's a number so that if you need it to reach out, you get that number. So I don't think it should interfere with that. It should be just additional, and it should also get those people who are not already in that.
Okay.
The plans of safe care come out when there's a substance affected infant, and they call Childline.
Yeah, so Childline's already
So the
there.
idea again
Although
is-
I think, weren't there some programs that, well, no, I think Childline is already.
and then referrals are made to the county, and then it goes out from there.
I like the idea of bypassing that for, again, those people who are not caught by that, plan of safety.
Right,
Because,
right. I'm just
They're
thinking.
self-referring.
Yeah.
Then that'd be an alternative for the families that have young children that's not being touched in the hospital.
Exactly. Right.
And I also like the idea that, again, it's not Childline, and so that, we can really socialize that number as a place, a non-punitive place to get help.
And it's low hanging fruit if you already have that line up and running.
That's great.
We can do
You guys have what you need?
Well, I guess my question is, yeah, if we go with that DDAP line, so the recommendation is that I'm wondering then, how do you push that line out? So,
We already have funding to advertise
okay,
that line, so I think we would need to probably pool some other resources to get the line out in other channels besides the ones that we typically advertise on.
okay.
So that brought up a question, that I had for later on. Are any of the recommendations going to be around funding? Because I think that if we're saying to establish these, whatever systems, all the things that we come up with, we should be thinking about whether or not there's any request for funding. to
Dollars.
implement them.
Yeah, I would suspect this would come at least at a minimal cost, only because, if we're now more widely advertising and expanding the services, the call center is probably going to need to staff, with additional people. And we'll have to provide them additional training on the services and resources that we're asking them to now refer to so that they're familiar with them. So there certainly would be a cost. My guess is we probably have the money to cover that cost through all of the various opioid and SUD related dollars coming our way. But, without really doing a detailed analysis on what the cost is, it's hard to say.
So what I would say, and I'm gonna get myself in trouble with this, we'll do it first time. Maybe one of the recommendations is, that there be a fiscal analysis of each of the
Yeah.
recommendations so that the legislature, whoever can make a
We can provide that
determination about implementing inclusive of.
I think that's smart.
Okay, so moving on to the third, did someone just put something in the chat? Kim,
I did. I didn't want to interrupt while you guys were talking, but I love expanding the current services instead of reinventing the wheel. I think it's great if we can use something that we already have and just expand upon it. I don't know what that phone number is, but it would be great to have it something easy, such as 911, but make it different, like 311 or something that really sticks with people. And then advertising it everywhere, which of course you guys were talking about. And then I think we can use our typical advertising things that we do, whether it's billboards and radio and all those types of things. But I do think we need to start thinking about how young people communicate like with the TikTok and different social media platforms, because those types of platforms are really being used to get information like this out and is not just for entertainment purposes anymore. So I think we just have to maybe rely on our interns or something to show us, what exactly should we be using to get this out to the most people possible.
I will say on the making it an easy number, does yours have,
It's 1-800-662-HELP.
662-HELP. My only caution about a 3-digit number is we haven't been successful in getting the General Assembly to fund 988, which is the National Suicide Prevention Hotline. So we have existing call centers for that in Pennsylvania, but it does come with if we're making a recommendation for something new and asking the General Assembly to attach resources to it, we can quickly find ourselves in a place where we have a program and no state dollars to support it. So I would say building on something that currently exists, like your number, would just help avoid all of that mess.
Yeah, I think there'll have to be some careful planning around how we advertise and message for it, because we don't want it to become a substitute for Childline, right? We don't want it to become where all of the child welfare, daycare, all kinds of calls are coming in. If we're really focusing it on these goals, which is to help families who are impacted by opioid use disorder or substance use disorder more broadly, we got to kind of remember that that's the focus. Now, you can't eliminate people from calling the number, with other questions, but we don't want to advertise it as anybody who has a family and has help and needs connected to resources, call this number. It does need to be a little more focused and targeted towards those families if we're going to use this number. If we want to use a different number and be more broad about it, I think that's fine. But this was really, the number that we're using is actually SAMHSA's national SUD hotline number. And each state is required to create a call center to support that. And so our call center, it's actually run through a company in West Virginia that does behavioral health call centers. They're the ones that provide the support for this, and they are trained on Pennsylvania's insurance system, our provider network, our single county authorities. They have databases of information that they search based on the caller. They're trained in crisis management, so they know when to call 911 to keep somebody on the phone if it's a crisis. And about a third of them are people in recovery, either from a mental health or substance use disorder issue. So, just again, kind of bringing the focus back to what's the scope of what we want this call center to do, and not trying to repurpose it for something that's much broader, and then we lose the effectiveness.
Conversation. The literature that I get every time my son has an immunization, so their schedules are different based on their age, or even back during his well baby visits, were, various colors, pink, green, whatever the medical center had on hand to reproduce them. They were, I believe, DOH. So it might tell you a little bit, 3 sentences or 3 paragraphs about that particular vaccine receiving. But what if there were a way with stickers to just use existing resources and do the 3x2 stickers, the rectangles that had the helpline printed on them, so it could hitch a ride on the information that already goes home, so that there's no conversation around screening questions in a pediatrician's office, or not that stigma takes a hike, but yet the number is still getting out there with maybe a sentence that describes why you can call that number. And we can, it'd be inexpensive, maybe. And we could send, thousands and thousands of stickers everywhere to our local Department of Health and medical practices. Something to think about instead of PSAs and costly advertising. If we decide to use that number and the fiscal analysis comes through that we could expand on that, we might be able to get the number out in cheap ways.
QR codes. Everybody likes QR codes.
QR codes, yeah. It's kind of a little mysterious still. QR codes would be great.
Okay, so moving us to number 3, establish a system of educating grandparents, those providing kinship care, and foster parents on how to care for substance-exposed infants and children, including information about available resources and supports. Provide education and supports for grandparents and foster parents of teenagers as well. There should be an intentional focus on preventing the next generation from suffering from SUD. The Biden administration this week announced, I think, $50 million nationally to support kinship care. The New York Times ran a relatively scathing piece about residential treatment for kids and in the child welfare system, and how that it's not really rehabilitating kids and it's not helping families stay together, our current policies. So I think that's a significant investment that they announced this week, and really trying to fix a broken safety net system targeting foster care families, right? But from my perspective, whatever this recommendation ends up being, it should be attached to the broader effort at the national level to really reform the foster care system to help more kids stay with family members as opposed to strangers.
What it's worth in Pennsylvania, it's a broader topic, kinship care, but we are doing pretty well in Pennsylvania in terms of intentionally reducing youth and congregate care. And for kids going to what would be traditional foster care, actually we just passed 50%, more than half the kids are now with kin than in traditional foster homes. And so we have a kinship care task force working with the courts. Like, we've really emphasized, if kids do need to be in out-of-home care, family finding, family first. It's a lot of what we're doing. And we have what I can offer, since you've already offered a line. But we do have a kin connector line on the website specifically, and it doesn't have to be a foster child, really any grandparent caring for their, and we know that's happened a lot based on the opioid epidemic. It's outside of the foster care, but the informal family agreements where grandparents are caring for kids, so they can access the connector, the resources and all that. But I think this does suggest provision of more specific resources towards substance use.
Mm-hmm.
And so maybe building on the current connector model in line with a focus on substance use. If yours doesn't catch them, maybe this will.
Mm-hmm.
So there could be a more specific toolkit or more directed education that it would be a recommendation to produce these that are really very focused and integrated into that system that you have already.
So would the group that we talked about in number one be the same group appropriate for sort of developing these resources and supports?
Maybe
Or is
Well, they
it-
wouldn't develop, but they would, I mean, I think that there would be, groups within our departments that have the subject matter expertise to develop these, but, I think that the task force would, see that they got developed and got to the right place.
Monitor the effectiveness, maybe request data, how many calls you get about this, that, our team connect line can get data, how many calls they've got, call us about.
Well, and that's one of the outcomes we should be measuring, right, is to John's point about Family First Prevention Act, is that what it was called? OCOF has worked really hard to continue to promote kinship care throughout the Commonwealth. It's really done on a county by county basis. So I think you'll see disparities depending on where you are in the state. But I do think with the investment from the federal government, there's a real opportunity to look more robustly at kinship care about keeping kids at home. And there might be resources we can tap into there as well to help support some of this.
I think just to that article too, is if you move forward as a grandparent or aunt and you leave the foster care system.
You lose the supports.
Right,
Yeah.
so you're disconnected, from financial support for the child, and you might be 65 and already retired.
Yes, right. It was a
Right.
really
It's a really
interesting,
interesting article.
that it was sort of, the article was making the point that the bureaucratic or regulatory requirements that we put on foster families are really hard to meet, the threshold of, right? So a lot of them just do it outside of the foster care system, but then, they can't access the childcare subsidies and the, all the things that help you be able to live your life while also raising that child. It's a real catch-22. I think that people, very, very much a cliff that people intentionally fall off of as they don't want to deal with a social worker coming to their house every however many months.
Or they may be perfectly fine foster parents, but we've got some regulations, you can have had a criminal history or something like that, that are preventing them from being approved as foster parents. And we're making it harder for kinship. That's one of the things we need to do better at.
Yeah.
I know there is some interest in this in the Pennsylvania legislature. There was just a hearing up in a couple weeks ago.
Yeah, I mean, it's even, I was thinking about the doula project that we have underway when a month or so ago, we went out to Cambridge Springs and we were talking to 3 pregnant inmates, and one of them was talking about how her mom was having trouble finding formula because of the formula shortage. It was like, well, she should be on WIC and you should be receiving, she should be receiving supports if she's caring for the child while the mom is incarcerated. And that was just us having a conversation like, okay, well, we'll talk to the right person and get your mom connected to that. But we need that on steroids.
What do you
I
think?
have a clarifying question. Are you guys talking, do we need to be more specific in this recommendation? Are you guys talking about the resources and supports being related to any impact regarding substance abuse or substance abuse prevention education materials, or is it just any types of supports for these families?
I think it's any type of support with a focus on families who are affected by substance use disorder, right? So sort of taking that clinical component and it's all the other stuff. In my mind.
Yeah, I think some of the education for the families would be what to expect with this child who's been affected.
Right.
But I think the other support should be anything else that this family needs to make them successful.
Mhm.
So yes, it is in this specific population, but it addresses all of their needs.
But I do see, as I'm looking at it again, I think it's a point of this recommendation is that it's for those providing kinship care and foster care. So we talked about kinship care, but there's probably a piece of this that talks about foster parent training
Yes.
that we have, that we should probably, again, expand upon.
Mm-hmm.
And because the work does happen county by county, the foster parent, the rules are more around hours than content. Foster parent training, and so there might need to be something about specific foster parent they may get a child that they're not prepared for.
And you don't know what you don't know. Right, so there were a lot of things that I didn't know. So it just what supplies to have at hand, what to do if it's been, 3 days and you've only accomplished 3.5 ounces of formula for one feeding, like you're in trouble. That baby's in trouble at 3 days. And the way you can soothe up and down, the vertical motion, no bouncing, no rocking that we're all used to because of the central nervous system disarray that's happening, with those early withdrawal infants. We're still in that 3 to 5, 6 month. They're still having symptoms, just how you hold them. Something simple and free, but that we just don't know until somebody tells us.
Well, are we saying that if the group established in first recommendation would be using its resources knowledge to inform the kid connector people in?
I mean, I do think that this recommendation somewhat falls squarely on us, on the Department of Human Services and the Office of Children, Youth and Families to develop the resources for kinship and foster parents. Unless you want to start talking about those informal foster families, and then again, I think that goes back to number one, a bit of a broader, like access to resources for grandparents raising grandchildren outside of the system. So it's a little of both to me. Right? Create these resources for the families doing it on their own, but assure the system that's overseeing kin and foster care are educating those that are known to our system to properly support these kids and families.
So is there a way then with your organization that if there were families that were not foster families, they could get access to education?
Yeah, they have access to the Kid Connector website and number, but it's not limited to.
But I mean, in terms of any of the education or trainings, videos or anything like that, they could access?
Yeah, everything out, yeah.
They have like this is substance use 101 for families that's dealing with children born affected. Because there's a lot of like disconnect with stigma focus and based just by not having an understanding of what addiction is and the different addictions and diagnoses.
Maybe there's something we could link to that you've already developed.
There's so much stuff out there. I mean, we could certainly do a search to see if there's something that kind of specifically fits that niche. We have utilized, it's a website called Just 5, and it was a tool. There's 6 5-minute videos that explain what substance use disorder is, how it affects the brain, signs and symptoms, that kind of stuff. That's very generic. It would not at all address substance exposed infants. And it doesn't provide any resources like, here's what you should do or where you could go. So I don't think that would be the right fit for what you're proposing, but I think what you're proposing is a really smart idea. So it would take a little bit of research to see if something already exists that we could link to, that was done really well, or if we need to just develop something ourselves. But I think it would be relatively easy to, pay somebody to, I can't, but pay somebody else to develop a video like that.
Yeah.
Yeah, I think that's a great idea. Incorporating some of what Dr. Johnson was talking about and Robin in terms of like what to expect developmentally. I also think as part of this larger conversation, not necessarily that video, but the resources, it would be important to also ensure we're talking about self-care for these kinship or foster parents. Because the reality is when you have a child with any kinds of special needs, and I am a parent of a special needs child, it feels very overwhelming a lot of times. And it's really easy to find yourself in a place of just like throw the hands up, like, I can't do this. I can't do this anymore. Somebody else has got to do this because I can't do this anymore. And so making sure that we're not just educating the families about what to expect with the infant, but what to expect you're going to feel as you go through this process. Like, it's going to be natural for you to feel frustrated and overwhelmed. And here are some things you could do when you start to feel that way. this is how you could get linked to groups in your area. You know, these are resources to read about how to connect yourself to counseling services or what you need. But I think we shouldn't forget about the importance of caring for the caregivers who are doing this work.
By the time they're teenagers too, I mean, I see a lot of grandparents who have their own medical issues
Yeah.
that are really limiting their ability to continue parenting these kids.
Yeah.
And that's where
That's
that,
a great.
you know, the next generation, those are the teenagers, that's when they start to get into substances themselves, and you've got grandparents who just have no idea what, you know, what to do. Plus, they've got their own resources, giving them medication.
All of a sudden, I feel very overwhelmed.
Moving us.
For a Friday afternoon.
Moving us to number 4, develop age-based screening tools for substance exposure and behavioral health that would be used during primary care visits. Providers should not rely on doctors alone to provide screening. Make these services eligible for reimbursement to encourage healthcare providers to participate.
So I think there are screenings already. It's a question of whether or not they're done and whether or not there's reimbursement. I know that a lot of the health plans now have quality points attached to many screenings, like depression screening and others. I don't know specifically about substance use disorder screening, but I know that many of the pay for performance do incorporate some of those. I don't know if anyone on the line knows anything more.
You can get reimbursed for screening teenagers.
Well, and we're
First.
talking here specifically
Yeah.
about age-based screening tools for substance exposure and
Oh,
behavioral health.
exposure. Oh,
Right,
okay.
so we're talking about for the kid.
Yeah.
The ages and stages
Right.
are modified,
Yeah.
maybe.
That's-
Here's what a doctor should be looking for.
Right.
Or
I think.
caseworkers, because
Right.
they sometimes do those in the field, right?
Right, which I think is the point,
Oh.
right, about not having just doctors do the
Right.
screening, but that you would have,
You need to know once they develop that.
So, yeah, that's why I was gonna,
Like for
let's say
home
nationally, is
visits,
there
like
one?
somebody doing home visits, nursing, that kind of stuff.
But is there anything more that the American Academy of Pediatrics spend out for, or talked about, or in stages for screening tool
Oh, there's tons.
for substance exposed kids?
Yeah, I'm sure there is. Yeah, I don't, right offhand, I don't know how specific it is for different ages, but there's so much information on screening.
I'm not seeing anything.
So would this be,
I have to look specifically.
is this going to get more kids than the regular screening that they would do for, I don't know, early intervention or others that connect people to resources? I mean, is this gonna add a significant benefit?
The discussion that we had last meeting was more, this was trying to target like the school age children. So in one of the goals of our task force, it specifically mentioned the other children. And this is trying to get those particular children. So we have a heavy emphasis on the infants and newborns. And correct me if I'm wrong, we have people that were there, but from my takeaway from that meeting was that this would be more like, this is something a school nurse could do, that sort of thing, like
Or an early intervention program, like your
Right.
preschool.
preschools,
Yeah.
school age children, you know, even up to the teenagers. Because maybe they're trying to parent their siblings while their mom is using opiates, that sort of thing. So, that was more the intention of this specific goal. So I feel that, yes, it would broaden the scope of what we already do.
So how, I guess, I don't know if we want to
Are
think
you,
practically this,
are you saying that we already do screening for substance abuse and behavioral health and primary care visits? Because certainly I've never experienced that with my kiddos or myself.
no.
Oh, okay. That's what I thought I heard. I'm like, what? But that's what we're asking primary care visits to do in the first part of number 4.
I think it's we're trying to figure out if we can screen those children who have been exposed so that we have a better handle on what types of behavioral problems might be attached to that exposure, which I don't think science has even told us yet. So I think we're a little hard
I think
there.
Well,
it's
in order to
more
try and
like
capture the kid, like, if you have 3 kids and there's an infant who has been identified as substance exposed, are you capturing the siblings, right, of that child? Is that sort of where the conversation was focused?
I think the conversation was more focused on there is not an infant in the home. There's 3 kids in the home. They're getting, mom, or I shouldn't, a parent started using beyond the infant age. And so now there's no screenings in place because there's no infants in the home. But now these 3 children are being exposed to a parent or a caregiver who is using, and how can we help them? That was my takeaway. Maybe I'm wrong.
And I was thinking it was I think we're all thinking different things for number 4 needs revisited. Because I was thinking it was a tool to help catch, so we could do some type of education setting assistance for these kids that were diagnosed with NAS, but there's no DSM-5 diagnosis when you're 4 if you had NAS when you're 4, right? But what is the data telling us? What tools do we have? How do we, is it a 504 plan that we eventually go down that path? How many kids need help? How many, I don't even know if the tool exists. So you're talking about someone who's parents.
I thought number 4 was from Dr. Lynch's, if I have it right, last meeting, kind of talking about the importance of screening and talking to kids and adults about substance abuse. I mean, I really feel like maybe we're even making it more difficult than it needs to be, like just asking those questions about drug and alcohol use and drug and alcohol use disorders.
So
I thought it was more of a screening to see if there needed to be more conversation or referrals or things like that.
Yes, and I think Dr. Lynch is on. I don't know if you have a comment.
Yeah, when from my perspective, when we were discussing the screening, it was more that it seemed that screening in general for behavioral health issues, and then for older kids, substance use disorder, which tools exist for that, is done inconsistently, and trying to ask that to be done more consistently, which would require sort of more time spent and things like that, was more the goal. So I'm not certain that it's within the scope of what we can do to develop a brand new screening tool that doesn't exist, as much as sort of ask questions about exposure in the household and perform sort of the typical sort of existing screening devices, particularly for behavioral health in younger kids.
I think we talked about school nurses, and I think we have to be sensitive to the fact that there are very few of them, and they're very over capacity, and so that it probably is not practical to add anything to school nurses in terms of that screening. So,
And most schools have SAP student assistance programs in their school with a designated liaison who specifically does like screening and early intervention and referrals to treatment for school-age children. So I don't know that we need to add another component in the school system to do that. I think teams exist already in that setting.
Yeah, there are.
I think the second sentence in there, I don't know if that's necessary. I think we are asking primary care physicians or offices to do this screening regarding substance abuse and substance exposure in their homes. And we're asking it to be reimbursable so that they're willing to really put the time and energy into it.
Yeah, I mean, there's several different types of screenings that go on at each
Right.
primary care visit already.
And many of them just look at the developmental progress of the kid.
Right.
And they could not be progressing for many things, including exposure to substances. So it's sort of a more broad identifying, is there any developmental issue?
And then what do you do if the 9-year-old says, well, yes, my mom's drinking every night and my uncle lives there and he's using drugs every night. Like, what does the physician do with that?
They call the resources either
Yeah.
Childline or
Yeah.
the other.
Right.
hotline
They think
There's
numbers.
nothing you can implement. It's just a screening tool.
Right, correct.
Okay.
so is 4 needed?
I was gonna say the biggest problem I saw with 4 was the first word.
Yeah.
Right? Like, are we developing it? Because I've skipped here, maybe this didn't exist, so I was gonna reframe it to see if you wanted to examine already existing, or as you said, Dr. Johnson, maybe we don't need it at all. But I definitely think we want to get rid of the word develop, because I don't think it's developing it.
Yeah, I mean, I thought Dr. Lynch made really good points last time. I thought, and Dr. Lynch is on the phone, he can correct me if I'm wrong, but I really believed that there was some power to ensuring that primary care doctors kind of take this on their responsibilities. Do I think it needs to be an age-based screening tool? Do I think we need to develop it? No, but do I think that conversation or some questions need to happen? Yeah, I think that would be a great recommendation.
And I think there are recommendations for screening for substance use, in teens and, kids as well, right? I think it's already part of, pediatric visits, right?
Absolutely. But that's for the patient's use, not necessarily the home environment.
I actually think that,
I mean, parents, you know, that's included.
Is that?
I mean, yeah, the recommendations there's a lot of recommendations. The thing is, there's like a whole slew of things that they need to be asking about.
Yeah.
And, but they can't ask about all of them, or the visit will be an hour long, just asking about the different things they need to be screened for. But so it's never done consistently.
That was exactly my point. I'm not even an office provider, I'm a hospitalist, so I'm not even asking all these questions, and I'm overwhelmed just hearing about all the things that need to be talked about at a 15-minute visit, and we're just supposed to physically examine the child, ask all of these questions, assess their growth, you know, all of those things. That's probably why I do hospital medicine. So, I think there has to be a better way to get this question done, and I think that was the point of bringing it. I wasn't aware of resources already in the schools, but I think that was the point of bringing the schools into it, because it can't solely rely on providers who are already overlapped.
I think that's right. And that's where I was going to, is I think the way that this can be reframed is around working with the Department of Education to make sure that these liaisons have the information that we're talking about here. Because even I wrote it down, but schools also have McKinney-Vento liaisons, they're homeless liaisons, they're responsible federally, they get federal funding to identify kids who are experiencing homelessness and connect them to resources. They're likely at the district level these days as opposed to like in each individual school, but those are folks that should have information, you know, about, look, they're the ones interacting with the kids that I think we want to have arm them with the tools that they need to be able to tell if a kid needs additional supports.
So I think it could be a common goal between several different groups. Getting out where kids are most likely to be seen, schools, daycares.
I was just gonna say, what about daycare?
Yes, right.
Like,
You know, that whole thing that we regulate at the department.
Oh, yeah.
All of that, like, I think it needs to be multifaceted approach. That way we're missing fewer children. I think that way we can.
But I think it's like outside of the healthcare system, what are the other touch points for kids? And that's where we should be arming people with.
Exactly.
Right, yeah.
Exactly. Right.
And maybe screening tool isn't necessarily the right term.
Well,
to
it's
use,
screening
'cause
tools.
that sounds very formal and clinical.
And punitive.
Yeah.
It sounds like another piece of paper that needs to be filled out or another box in your EMR.
This is
that
more
needs to be
about,
checked.
Right, and then they give you
about signs and symptoms and risks and like
right.
what to notice in children when you hear or see.
Right, a tool to me feels very, I certainly think there's a time and a place for them. I don't mean screening tools should go by the wayside, but I think to that point, if you're already overwhelmed with the requirements that we've put on you, we eventually get to the point where last time I went to the doctor, they handed me an iPad and were like, here, answer these 35 questions and bring it back up front when you're done. And nobody's watching me to see, am I taking a long time to answer that question? Am I, you know, it's self-monitored, and I don't feel like you get necessarily the best results there. If we should be enabling people to have conversations that allow them to identify these things outside of a checklist.
Well, you're talking about a situation where these people spend, in most cases, multiple hours every single day with these children. I mean, they hear things, they see things, they notice when kids are acting differently. They overhear conversations about, my mommy was hitting my brother last night, or, things like that. So I think arming daycare workers, preschool employees, that's a really kind of missed population of people that could help identify some of these challenges earlier in the process. And then also ensuring that our SAP systems in the schools are operational and robust and have enough funding to really support them the way they should be supported.
Mhm.
The problem with the SAPs though, it's all voluntary. If they don't want, if they reach out to a family, the family doesn't want to talk with the SAP, they can't. It's very voluntary.
That's our whole
Yeah,
healthcare
right,
system though with
exactly,
SUD, I mean, it's all voluntary.
It is, yeah. So if you have a family that they're really worried about and is getting referred to the SAP officer, then, they can reach out. Family doesn't return a call, not a whole lot they can do.
Except,
Yeah,
What we can do though
I
is
mean-
arm them with the resources,
Right.
and I think if they develop the relationship and the trust and say, okay, I see you're struggling, here is something that can help you. I think, but, to require them, I think it's just gonna drive more people
well,
away.
and I think
so.
that's
Yeah.
where some of their challenges are.
Mm.
So,
They are a boots on the ground, able to say, oh, hey, I saw that Meg came to school 3 times this week wearing the same outfit, right? Like that type of thing. And I think even though it might not be a perfect system in the sense that it's voluntary, it's still a place where we're completely missing that these kids are falling off the cliff when they are school age, because people exist in systems rather than as people.
the programs need better resources too.
well, that's
Yeah.
what I was
I mean,
gonna say.
The challenge in most
If
school
you can
systems,
give them more resources,
the person who's
For
doing
them.
the SAP
yeah, because
program
they're doing it.
is already serves another function in the school. So it's the guidance counselor,
Yeah.
or, it's a teacher in another classroom who just volunteered to be part of the SAP team. I think we really need to start investing in more behavioral health focused people in schools, that is their sole job, is to help address mental health and, identify early intervention strategies for kids. I don't think we can continue down a path of one guidance counselor for an entire middle school and expect them to be able to do appropriate prevention services in the classroom, plus see children who are in crisis, plus identify through the SAP program kids who are at risk. We've got to statewide start funding positions that are solely dedicated to addressing behavioral health needs.
You put that in here.
Yeah.
I get it.
I think the other thing too, is the SAP, they have the hardest time finding resources to work with families.
Well, that's right.
Yeah, I mean,
It's sort of we
it's
can
going-
build it, but they're
yeah.
going to come. So
Yeah.
you want to make sure that you have the information available, which is why I like the idea of part of the recommendation directing state agencies to work together to make sure, I don't know, for lack of a better way to say it, that the SAP offices in our local school districts have the resources that they need. There's a fancier way to say that.
Yeah.
They need case managers, basically.
Department of Education.
But yes, it would include Department of Education, that we should be working to examine the existing resources that are available through SAP programs and then making recommendations about how to bolster them.
A little torture over children.
Mm-hmm. Mm-hmm.
So I feel like this goal, this recommendation is more into use, or not to develop, but to use, resources already available to screen children for substance exposure, at multiple touch points, including daycare, schools, physicians' offices, et cetera. And provide resources to the to these places, including the SAP people. I'm not an English major, obviously.
And I would say identify rather than screen. That's just me, but I think
that's a good word.
yeah.
And exposure is tripping me up still. Does that mean you're exposed to an adult's use of a substance, or are you exposed to that substance or you're using the substance yourself?
I think it could be all of the above.
So
right?
maybe it's word exposure.
Well, I think that exposure to me means you're around it in some way, shape, or form.
So because a lot of the questions now focus on, are you, especially for teenagers and middle schoolers, are you using these things?
Yeah.
And nobody's asking is
Are you exposed to?
That's right.
or caregiver using these things. So that's what, I think it broadens the questions that we ask. And then I think including some sort of statement about providing additional mental health support in schools would be appropriate. Is that, in theory, you prevent, or you increase your mental health support, then you maybe in the future prevent. Yep.
Is there a way just to ask for a price tag without it becoming a recommendation? Like, is there a way to make a recommendation that we figure out how much a licensed clinical social worker would cost?
I don't think you want to go down that. Only because we have 500 school districts in Pennsylvania.
And then within them, 7 schools or 2
Yes.
schools.
Right.
So you would never chase it, it'd be a rabbit hole.
Yeah, I think so. I think,
Schools have 100 kids, some kids, schools have 1,000.
right.
Yeah.
County class size, how much would it cost by
We
that?
just
You know,
need
like population base.
But we should work to identify and attach the appropriate resources to it. I mean, that should be part of what I would imagine this working group would do. You have had
Yeah,
something you
April
wanted to
keeps
say. April.
looking like she
Sorry.
wants to talk.
Nah, I'm just thinking about the educational piece as far as something that Angela said. If they identify an adult in the house maybe using drugs, and we're not talking about what drug they're using, whether or not it's actually drugs, whether or not it's prescribed, not like who, and the first go-to is, oh, call the child line or another resource. So if we're gonna arm people, with that type of power, who's gonna, like, are they gonna be well educated into, like, what is drug use or severe drug use or substance use? We get a lot of people making diagnoses without understanding, or their family is actually diagnosed with substance use disorder.
Right,
So-
substance use and substance use disorder
Right,
are two really different things. I mean, there are many children who would say, well, my daddy has a beer when he watches the football game every week, or my mom has a glass of wine every night when she takes her bath. And that doesn't necessarily indicate a problem for that child. It doesn't necessarily mean that the child is not receiving good care at home or needs some kind of intervention service. So I think that's a really great point, April, that, it's not just about identifying where homes have substances or uses occurring. It's about problematic use. And, how do you make that distinction in identifying and then using that knowledge to refer to resources if necessary?
I think it's a good point that if we're going to be asking people to do more screening or identifying, then they need to be educated on what to do with that information.
Yeah, I would absolutely feel like an automatic child referral is not helpful.
Yeah.
In those
I'm
situations.
not advocating for more calls for child, unless there's actual suspicion of child abuse.
But, I agree with more like the secondary call line sorts of resources and, additional questions that they can ask to identify, is this actually a problem, or is, mama had a margarita, Friday night, so.
So I think that as we are promoting this number, it really has to come with education, right? I think that it needs to be clear what our goals are to help families and support families, and, that information needs to get out. So I think it's, not rushing everyone to identify without having the background education on what to do.
Yeah. And some stigma education in there too.
All right, in the interest of time, I'm gonna move us on to number 5. Okay. Require agencies that provide plans of safe care to report data on outcomes to develop a system of best practices.
I
I'm
would
fine.
like to see those be 2 different ones if possible, like require agencies provide plans, the data, report data on plans of safe care, but also I think that it sounds like some counties are doing a really great job with plans of safe care and others aren't. I would love to see them kind of develop those and distribute those best practices before we get the data back.
Yeah, I would think, I know that we'd want to develop best practices based on what we're learning from the data, but again, you're talking about that's years away necessarily, right? Before you know the outcomes, so we don't have to wait to develop best practices until that, I think that's what you're saying. I will go to the data again, though, that if you're looking at, and I'm not at all, or we should be providing data on what's happening, when you start talking about outcomes, are you talking about 5 years post-birth? Are we tracking children? Like that's not something we're really able to do as a child welfare system. And again, back to the idea of surveilling and all that. So when we say require agencies that provide public safe care to report data on outcomes, I just want to think that's on outcomes of like their direct service or the first year of life or something like that, right? On the work that they're doing versus what happened to this kid 10 years later.
Yeah,
Yeah,
John, I was, sorry.
Yeah.
Oh, go ahead, sorry.
Yeah, no, I think, I mean, I was hoping to get like simple data, right? Like how many families were offered a plan of safe care? How many said, agreed to a plan of safe care? How many of those cases without a plan of safe care had a report come into Childline within the first year? Like, I think I was looking for like, is this practice working? If that makes any sense.
And maybe in my brain, so I differentiate sometimes the outputs of a system versus the outcomes, right? So definitely should be accountable for the how many of this. And maybe some sort of outcomes, like you're saying, like how many of these might have ended up in foster care. But I was just trying to manage expectations about long-term.
Yeah.
I mean, really, that's what we'd want to know, I think, right?
I
Like, were
think
these kids
ideally-
kept out of?
Yeah, ideally, we'd love to know exactly what happened to them, exactly their outcome, but I think that sensitive to the fact that families don't necessarily want to be tracked. And so, having this detailed information, number one, people are not going to want to provide it. And number two, I don't know, it seems quite invasive and more stigmatizing. So I think we'd like to get a lot of this data, but at least having some of the outputs would be great. And then maybe there are groups that would do a concentrated study
Yeah,
on a
or
group
work
of.
with them, maybe commission a study where you get parents' permission,
Yes.
find consent, maybe even they get paid to participate, who knows?
Yeah.
right?
I think that would probably be preferable than to require us to try to track everyone that
If the
goes to that
state
system.
tracks people over longitude.
That might even reduce the number of families who actually
Agree to the,
agree to.
if they know that they're gonna be
Yeah,
tracked later on.
So just the individual entity that's doing the plan of safe care would be reporting the data. Right, that's what we're talking about. So if it's Tioga County and they had 37 plans of safe care this fiscal year, 34 parents engaged, 16 dropped out at month 2, like some metrics.
Yes.
And that's pretty not stigma. And then Penn State's doing, Dr. Core, right, is leading a big study on long-term outcomes. And that parents can sign up for, much like you sign up for a Geisinger study. So maybe that voluntary commitment of the parent, and they can leave that study whenever they want. So there's no tracking going on.
Yeah,
I
I
would
think
like
we're trying to see, is the plan of safe care preventing a fatality, near fatality, future possible report of abuse. And we know in the first 4 years of life, that's certainly the most dangerous time. I think we have all the data we would need somewhere.
Well, I don't know that we have a good way to link that data. I think we have the safe plans of care, but when a child gets in foster care or there's a report, I don't think that we have a reliable way to link that.
We were working on that last meeting.
I'm gonna say Dr. Walsh came on screen, so.
To what John was saying, and Leslie, I would like to know what you're talking about as well. Like, I would like to know that information. But to what John was saying, the outputs versus the outcomes, we could not say that the plan of safe care in and of itself prevented entry into the system or a fatality. Like, we wouldn't have the capability to do that. And that would be a longitudinal study that took in all the variables, all the pieces that systems that the family was involved in, that we would have no access to unless, like, I think it was Robin said, they volunteered for a study. But I think that at the county level, for the agencies to be able to tell us the, the numbers, I call it like the counting widgets piece, we definitely could, look into that type of thing. But to make all of those connections, there are just too many variables for our system to handle it. A university absolutely could, and Chuck's on too, so he could correct me, but that's not within our capabilities. But I'd like to know it as well.
It's so frustrating, putting so much energy and efforts into a mandate that you're not sure if it's working or successful. That would be really frustrating.
We can say how many, children have received them, that, we can give some information related to, whether it was more this year than last year, whether certain counties have engaged when they hadn't previously engaged with families. And that, gives us some information.
That would need to be interpreted, because you're looking even at like referral numbers, but if referrals go up, maybe that was because we did better education of physician, not that there was more use.
Exactly.
Correlation does not equal causation. So, causation, like big point hammered home when you're looking at research studies. So
It would be important to, I think, with the outcomes, to have a team look at that and to have input around it, maybe that commission, something in the future. So I think a really important question to ask would be, why did you not want it? Or why did you leave the plan of safe care program? So that we can fix that, year 7, and we find out that a large portion of parents engaged initially, but then dropped out of participating in the plan at month 3 because they didn't feel like they needed it, or because it was too intrusive, or because it led to some other disaster they didn't see coming. Like that, why they left.
Employed and didn't have time for it and actually doing pretty well.
Yeah. Well, didn't need it anymore. Baby's thriving, or they didn't need a plan at all. Because statute doesn't say, Michelle does, or Dr. Walsh, it doesn't say how long the plan has to live, right?
It does not.
No, so it could just be very brief.
I think a recommendation around requiring additional data outputs to be determined, whether it's by the other group or request a proposal on what could be tracked and captured based on what data we have available.
we could just say that task force should investigate opportunities, again, investigate opportunities for long-term or longitudinal study into these kinds of safe care.
Turn to the guys, people in the back, you got what you need?
I think so.
Okay. All right, number 6. Combine resources of the Centers of Excellence, DHS's Office of Child Development and Early Learning, or OCDEL regional offices, and Pennsylvania's Managed Care Organizations, or MCOs, to map locations of local and regional resources to further help providers and families access services and supports. So what kinds of resources are we wanting to be mapped?
Is that number 1? Same ones we were looking for.
We have a pretty robust, looking at my DHS folks, but there are a ton of resources available. I'm sure Chuck could speak. Is Chuck on the phone?
Yeah.
Yeah, I'm here.
What do you think about that, Chuck?
So that reminds me of the resource and referral tool, or what we're calling RISE PA now.
Yeah.
Isn't a lot of what that is doing is identifying local entities, community groups to sort of coordinate supports for people, whether they're whatever system they're in or whatever their needs are.
So,
So I think this is similar to 211 and the discussion you were having earlier. And my challenge at the beginning of the RISE PA conversation was that I really did not want it to be a duplicative tool to 211. That feels like a gigantic waste of resources. And I think where we've landed with it and having the health information organizations or the HIOs procure the resource and referral tool on their end will help make sure it gets embedded in the right place, right? It feels like that's a tool that we want a physician to have access to so that they can plug something in and say, this family needs food, a food pantry, right? And that is what the resource and the RISE PA tool is meant to do. So I think, can you give us an update on where we are with that, Chuck? Do you know?
My understanding, it's from the last update from Martin, is that they're in the final stages with the HIOs to identify a vendor.
Okay.
And I think it is his last report out. I think they were looking at it hopefully going live sometime midpoint next year in the summer.
So you will be able to put in a need and get connected to a resource in your area using this?
Yeah, it won't be, correct me if I'm wrong, Chuck, but it's not like I would just go to the resource and referral tool and type it in. The physician would have access to that, right? So
So just
Yeah.
because we're talking
not
about.
necessarily, but
Community organization.
Commu-
So like
Okay.
how now like a physician would like refer somebody out for an endocrinologist. And then they get a report back that, yes, we've met with them, this is finding. So this would be also closing that loop with community organizations. So if a physician says, oh, I'm going to connect you with the food bank, they would be able to then see like, okay, they did follow up and received the services that they needed. So kind of just providing a little more to the picture. So community-based organizations would also be queued in and sharing some of that information.
it was the best way we could identify to keep the information real time. Because I worry if you just stand up a website, we went through this for a long time about substance use treatment, like the number of beds that are available. It's like, well, unless you have somebody 24 hours a day calling every treatment facility in the state, you're never going to get a real-time picture of what's available in real time. By embedding it in with the HIOs, it also links to the electronic health record component. So it's like a back-end function of connecting people to resources.
so do we need this recommendation?
I don't think, but that's just me. And you could say certainly as the RISE PA tool launches that, we should be monitoring the uptake in, community-based organizations, whoever's using the tool. We want to see, is it being used? Did we build it? Are they coming? But that way it's less 211 focused because that exists. We didn't want to duplicate that.
And that would be available to the public.
Great. Okay. Making progress. Number 7, provide Narcan to at-risk families at discharge after a baby is born and make it available at subsequent home visits and medical appointments. Training on Narcan could be provided through the Department of Health or as part of WIC.
I'm all for it.
Yeah, I was gonna say, I think you all have done, between your two departments, just an enormous amount of work to get naloxone out into the hands of people who need it. But I think any opportunity to do more of that is good.
The one challenge we do still hear from particularly some doctors in hospitals is the ability to provide the Narcan at discharge. So unless the hospital has a pharmacy, they don't always have naloxone on hand that is intended for distribution to the public. So they have naloxone because they use it, but it's typically in a syringe form or in dosages that aren't conducive to what we'd be distributing for public use. So I think that unless Dr. Lynch corrects me and says that has changed, I do believe that that is still a challenge for some hospital and emergency department staff. However, I think that there could be conversations to try to resolve that issue, either through us being able to help fund the cost of those things or supply product, or even, giving them in the hospital the QR code to go onto our mail order program. And all you have to do is type your name and address and it gets shipped right to your doorstep. So that could be part of the discharge process where they just have the tablet there and say, hey, fill out this information. And then also, could give a QR code on a pamphlet for the training, because the training is always available on the DOH website, free of charge, on demand. So you wouldn't have to do something special advertisement.
So some hospitals, I know we did, partnered with organizations that would give us the Narcan to give people on discharge. But I love the idea of the QR code, but I think that also working with hospitals to make sure that they had the supplies that they needed, I think that's great too.
So maybe the recommendation would be for like our two departments to collaborate and work together to ensure that hospitals are able to have access to provide the naloxone free of charge.
Sure.
This recommendation came with the instructional video, not necessarily educational in and of itself, but just the messaging to parents as they leave that the Narcan medication can be used for children's safety. And someone that they trust, a physician or, physician general saying, like a minute 36 long, not necessarily have to necessarily use it if that's a separate issue. And there's already training videos for that, but just the messaging. I want to raise the point with QR codes because I like them too. And I like that they make our life easier, but it doesn't make life easier in rural Pennsylvania. And for those families that don't have smartphones and we don't have internet. So they're, or tablets.
I think you couldn't do that alone. You'd have to do another method as well. But I think people who have them, yes, but yes, I come from rural Pennsylvania and there's not a service very many places.
At discharge, if somebody did it as part of the discharge.
Like the car
They could do
seat,
it
this
right
is how
there.
you use the car seat.
Instructions.
Yeah. So one thing though, I don't see in here is, we're talking about Narcan and we're talking about, just kind of prevention. One of the things that I've seen in some reports is that many women with substance use disorder in pregnancy aren't getting treated with medication assisted treatment, right? And I think, we're all aware of that. And there are huge disparities in that. Women of color are getting treated much later and at much lower rates. So that here's an opportunity to make sure that we're reinforcing, getting that treatment to all women during pregnancy. And I think that, comes into our prevention. We probably need to put that in somewhere.
And the messaging around how your prescription might change. Right, postpartum.
Or just even
Go back to your provider.
Right. I mean, I keep thinking back to that visit to Cambridge Springs. One of the women, they all suffered from some level of substance use disorder. I think 2 were on MOUD prior to being in the facility. Both had been weaned off because of their pregnancy. And we were like, that's not what we're supposed to be doing. So we were able to make a lot of those connections with those women. I mean, we had me and the Secretary of Corrections sitting there and it's like, okay, well, we're going to solve for this. But there's a ton of, there's a lack of training, I think, and understanding about.
Afraid of pregnant women.
Yeah.
They just tell them not to take anything, which is not
ideal, right?
But we have an opportunity to educate.
I don't hear it quite as frequently anymore, but I used to hear all the time, moms would come in They were on MAT, usually Sunday text during pregnancy, and they were told, oh, your baby will be fine, your baby won't withdraw, which makes steam come out of my ears because of course they would still experience withdrawal symptoms from that. So just education again, over and over and over again.
Yeah, I mean, at Cambridge Springs, they were only doing methadone.
Yeah.
And it was like, we've evolved, I mean, on that, and especially if it's a women's prison, right? I mean, I don't mean to disparage the Department of Corrections, but I think cross-agency training as well as in the community would go a long way.
Well, just even screen. They're not, I mean, not only they're not treating women, but they're not doing a lot of screening either with pregnant.
Well, in these studies that we've seen though, these are women who are diagnosed with OU and not treated.
Right, well, I'm just saying that, I agree that they're not being treated, but even just a general population, OB-GYN aren't doing the level of screening that they should be doing to identify.
And again, if we're telling people to screen, we need to really make sure that they know what to do then with that information.
Right.
And that is in a helpful way.
Right.
That's what prevents them from doing the screening in the first place, is because they don't feel like they know what to do once they have the information.
I was looking at the atlas email that came out, about the percentage of substance use treatment providers that have onboarded with it, and it's growing. And then I was looking at Shatterproof, and it's interesting their perspective and how much it's like their first national principle. They have 9 of them, I think, for Shatterproof, is the screening in all settings, and how they're really spending a lot of time and effort and money to try to make that happen. Wonder how they're doing it. So I would have spent some more time seeing what Shatterproof is doing, because so many people seem to really respect that organization, that movement. It seems upbeat and positive. They've got to be doing something right when it comes to screening. I just don't know what it is.
Is this a new recommendation? Getting treatment to all.
Way to go,
women?
Dr. Thompson.
It sounds
I
like.
know, I haven't been here for a while, I need to.
No, you don't. It's a good thought. I think it is different from the Narcan discussion,
Right.
for sure. Yeah, I think it's.
But it really is more in the prevention, I think we need to.
We should evaluate, honestly, when we got the first couple rounds of SOR funding and SOAR funding, and we did convenings with, like, for example, emergency room doctors, right, about warm handoff. We should do something like that as the science of MAT has evolved, is regroup with those clinicians in the community to make sure, I mean, part of it, I think, is just, when I asked about methadone, I was like, that's it? We're not doing more than that? And they were like, well, that's what we've always done. And so
I think you're right. I mean, a series of summits with both state correctional institution staff and county jail staff
100%.
to really talk about MAT, not just in pregnant women. I mean, that would certainly benefit our cause as well. But it would benefit all individuals with substance use disorder who are being denied either continuation of access to the medications or initial access to those medications.
And they need arteries too.
Yes. And I think for the purposes of this group, you could certainly incorporate that into the broader work that DDAP is doing with opioid funding that continues to come in. But for the purposes of substance involved children and families, you could sort of shrink it down, right? So that we have a summit that targets providers who see OBs and others that work with pregnant or postpartum women, and making sure that they're understanding the science as it evolves around MAT, or I mean, it's now MOUD.
So,
they're used, but
I think, like from this vantage point, some of it sound great, but as a practicing physician, that doesn't sound great.
We would need to attach it
physicians
to,
don't
like,
have any time.
No.
So I think if there's a conference that's already going, so having this as
Yes.
a module that you can insert into conferences that are already happening would be
And
great.
attach credit hours to it.
Yeah, it has to happen. But physicians don't have time.
Yeah, fair enough. So that should be part of the recommendation, that Yeah, absolutely. I wasn't, I didn't mean to
Yep,
pigeonhole
agreed.
us that much. Is that helpful? Okay. Okay, number 8, provide medication lockboxes to families to prevent accidental or unintentional poisonings. And I love this. Yeah, it's pretty straightforward. It's like gun.
And some places do this already. You know, some single county authorities are very good at providing lockboxes. Sometimes pharmacies will provide them. I think it's just very inconsistent across the state. So we'd have to figure out some strategies to expand it. And you could do it in a number of ways. I mean, pharmacies is a great access point to do that. You could do something similar to what we were saying with discharge instructions to order Narcan. You know, if they're being discharged with an opioid prescription, or they're being discharged and they were a pregnant woman, you know, who had been using substances, you could have them order it, you know, right there online and have it again shipped to their home. We could provide stock to the hospital to be able to hand out. There's lots of different avenues to accomplish
And is there
that.
funding for something like this?
I mean, we don't have anything budgeted specifically for this, but I think there's enough funding to
I mean, it
make
would
it
be
happen.
great to be able to have some of these with a health number on it.
Yes.
Yeah. That would be a great, promotion to.
And certainly, you wouldn't want to necessarily talk about giving it to every single person who's discharged from a hospital, right? I mean,
Right,
we're
right.
talking
We're
about a
subset.
more limited scope of individuals.
To a certain extent, I did just take care of 3 sisters who got into family friends climbing, and 2 of them required intensive care. So, and that particular person doesn't have, so we can't even like just limit it to small children. I understand I'm talking about a very specific anecdotal situation, but we can focus on one part and then maybe stretch it to other places. So if that's a situation.
Like the kin connector. Could you?
Yeah.
Could it be, if these are grandparents primarily, would they tend to have more prescriptions than the 30-year-old? So if there was a button to click there that you could request.
That'd be a lot. I'll say quickly on this, and you might not want to mess with it because it's actually a good, clean recommendation. If you saw the agenda, we were going to talk a little bit about adjustments. We're not going to have time for that today. The adjustments are way up. If you look at 2018, 2019, and then in 2020, they jumped up. In 2021, they stayed very high. Like it's definitely been an increase.
And this is ingestion of.
Ingestion. So we're talking about, so child fatality and near fatality reports that we get. So it's not just opioids, it could be prescription medication, or even like candies and gummies and things in there, but something that caused a doctor to certify it as a fatality or near fatality of suspected abuse. And again, with the county administrative system, a caseworker might have checked ingestion, another time a different situation, the worker might have checked lack of supervision. So it's not perfect data, but certainly like, startling increase in the amounts. I have it all with me, but it's all online also, but whether you want to do a recommendation specific to like broader to ingestions, like I think lockbox is one of the strategies, whether you would add a line saying, study the increase in ingestion fatalities and develop other strategies to address.
I think that's smart.
Yeah.
Yeah, because lockboxes aren't going to solve
No.
kids getting gummies, because people aren't going to lock up their gummies.
No, and those who are in active addiction don't always put away what substance they just used. We know that's why we need Narcan.
Yeah, and I would say just anecdotally, because I read every fatality and near fatality report, a lot more near fatalities than fatalities, and Narcan is often administered. I'm reading the report on a child who's given Narcan.
That's
We could put Narcan in the lockbox.
That's a great recommendation, John. I think all of us would appreciate looking at the ingestions.
You guys good?
Okay.
Okay, last one. State, county, and local government should direct resources and collaborate with Pennsylvania's colleges and universities to expand the state's human services workforce overall. Yeah, cast a wider net. We've got to figure out how to get more folks in the door to do this work.
So I don't see any recommendation around goal 4. Does there need to be something?
Ensuring the Commonwealth is compliant with CAPTA related to identifying substance exposed infants and is developing multidisciplinary plans of safe care for these
I
infants.
do think the plan of safe care data collection is next to that.
So, okay.
And I do believe, although maybe not a recommendation, I know we covered it because I know we had, the commission, we talked about to make sure that they felt that we'd had a sufficient discussion about CAPTA to be able to respond to the question as to whether it's on. I don't want to speak for you all, it was my understanding that we had enough to respond to that question.
I don't think so.
Okay.
One of us reminded us these kinds of public comment.
Yep. Actually, I think that was our final recommendation, so I think we've got 15 minutes. Leslie, sorry.
Yeah, I thought the last one was pretty general. I mean, it's a very general recommendation. I think when you look at it, you wouldn't really know how to go about doing that. Do we have anything more specific? Do we want universities and colleges to focus on education regarding substance abuse, or do we want to do anything on child welfare or combination, or look at, recruiting more students to go into this field of study? I mean, I didn't know exactly what someone reading that recommendation would do with it.
Yeah, I think it's a broad and overarching recommendation, speaking more to the point about workforce crises across the board in the human services and healthcare systems. And that I think we've got to get away from, this is just my perspective, but sort of a rising tide has to lift all boats from my perspective, and where we kind of pick off these professions and give rate increases here or, recruitment and retention bonuses over here, and we don't do it across the board. We're just constantly playing like a game, I guess, whack-a-mole, right, is more. So I think it's important to be looking at the system in its entirety and not just within the kind of subpopulations that they're all important.
I think the task force or the work group then would be responsible for documenting how that recommendation is met, right? So they would need to get information on what work is being done to fulfill that recommendation.
I know our department had a conversation specifically with the state system of higher education, the chancellor and vice chancellor to talk about this issue specifically. And we had a really, really good conversation around, what it might take to get more individuals into our workforce. And some of it is going to really mean those of us who are more experienced or older might need to think a little bit differently about how we recruit for these positions, and the things that are important to young people going into and coming out of college are very different from the things that we felt were important when we were that age. So things to us that were important were, longevity in a position and the ability to move up within that position and a desire to kind of stay with one employer or in one field for the duration of our career. Younger people don't place as much value on those things. They're much more fluid in their movement, both across organizations, but across disciplines. I mean, they're not thinking, well, because I graduate with this degree, that's what I'm going to do for the rest of my life. They're thinking this is a jumping off point. This was the degree I have, and that's where I'm going to start. But if something else seems more interesting to me or opens up or pays better or has better vacation time, I'm going to go do that other thing. They don't really limit themselves. And so our kind of recruitment efforts to build the funnel and bring people into the field needs to look different than what it had previously. I mean, things like we can't anymore talk about paid versus unpaid internships. There's no such thing as an unpaid internship. Nobody's going to take an unpaid internship. Now everything has to be paid. We have to look at apprenticeship type programs where we're paying them to come in maybe while they're still in college to start training to do the work and hope that they'll like it enough to want to stay in that organization and do things. So I think there has to be a mindset shift very broadly about how we recruit younger generations to do this kind of work, and also thinking about how we recruit people who really care about this work and maybe aren't young people coming right out of college, but they care a lot about this field and want to make a difference. How do we make opportunities available for them to get the training, the education, and the experience that they need to bring them into the workforce, especially in the SUD space? You so often hear about family members who have been impacted by it and want to contribute. And usually that means I'm going to create a 501c3, or, I'm going to stand up a recovery organization because it, gives me purpose. Well, maybe there's an opportunity to actually bring them into the professions in the behavioral health workforce if we give them the opportunities to do that. And that probably means paying for their education, giving them the opportunity to seek the training and certifications that they would need to do it. So that's my 2 cents, same. We did a presentation for 2 hours this morning together, and I did that a couple times where I was like, same. I'm not gonna repeat myself. All right, well, in the interest of time, we have about 9 minutes left before I turn into a pumpkin. That was bad. Appropriate for
I
this
didn't
time
like
of year.
that joke.
Very Andrew.
Should I open it up for public comment? Is that, okay, so at this point, we'll open it up for public comment.
Leslie just said we don't have any recommendations on work surrounding stigma reduction.
I think that's sort of embedded in several of the recommendations we were talking about, to be honest. I mean, our department is doing a very targeted stigma behavior change campaign. I don't know that we need to do something separate that's specifically targeted to reduce stigma. I think we need to focus our efforts more on embedding that message in the other things that we're talking about doing. So, April made the suggestion about a video to help educate people about what substance use disorder is. I think there's a stigma component of that. Any of the resources that we make available, there's an opportunity to include either stories of people in recovery or families who've been impacted by it. So I think it's more about embedding that in kind of each of these things that we're working on, but that's just my.
I just default to your.
I'll raise one quick discussion point if there's not anything else.
Sure.
Which is,
Are we good on the phone?
I know we had some discussion about how the recommendations get presented. Are they unanimous? Are they consensus? Are they majority? So.
I had asked that question. I was asking actually April in the terms of the universal screening tool. I didn't.
Because we're moving.
Yeah. And I wanted to make sure that we all felt, because there's no charge in the statute, right, one way or another. So if we're all comfortable with these recommendations, I think we can say that they are, inclusive of the entire group. But if anybody wants to take a different approach, we can certainly do that.
And that did not make it into the recommendations, right? Universal screening, or it did?
It did not.
Thank God. And when did we decide that? Did we decide that as a whole last time, or?
I don't think
can't
so.
remember.
I don't remember the discussion.
I mean, I remember April's opinion, but I don't remember the rest of the task force.
And I do think every expert, I see their presentation. I just saw one from Children's Hospital of Philadelphia. I mean, that's what I think most places recommend. So while I see that it did not make the recommendations, I also would love to know more about that. Yes.
I think it should be part of a discussion for a broader work group. I think the challenge that I, share with April is and just me, but I really worry about the bias associated with universal screening. And that if we don't have the right training and resources attached to it, that it really could create a lot more opportunities for involvement with the child welfare system than are necessary. That I don't disagree that from a policy standpoint, the idea of universal screening makes sense. It's the nuances that go along with it that I think we have to be careful about, but we could certainly put a recommendation in that we continue to explore.
Further discussion.
Yeah, you know, or monitor the development of, I don't know.
This would, the universal screening tool just in the medical setting, right? Like OBs?
I think we're talking specifically about screening, doing urine drug screens on all pregnant women.
I thought we were talking about like expert screening tools that are with OBs.
No.
We're talking about completely different things.
Universal drug screening.
That's testing. I'm talking about screening. Like, right?
So I think the discussion,
They're two very different.
I agree, I think, the wording that we are trying to use here is testing.
Oh, I don't think we even talked about that.
It was a discussion last meeting.
Oh, I thought it was a screening tool, like the physician would do expert or one of the other ACOG recommended, everybody recommends screening.
We're talking about it.
Testing wasn't,
Yeah, I don't think we really.
it was, someone said that they reported a mom who, was it you?
Yeah,
Who
so
was seen early in pregnancy?
the way, so there's a current law that, and the way that at least the way the local children and youth office interpreted it was that any positive urine drug screen during pregnancy was referred to children and youth and the child line referral. But that stemmed from that law, and I know we're short on time, so maybe I misinterpreted exactly what we're specifically talking about, and universal urine drug screening on all pregnant women, which is not okay.
But I think it's very important to distinguish screening from testing. Testing is urine, right, and blood, like you're doing a test of a bodily fluid to determine if drug use has happened. Screening is like SAMHSA.
Right, but they are
Well, I
called
think
urine
that's-
drug screens.
Yeah.
I mean, that's officially what they're called.
But this task force wasn't recommending universal drug testing of pregnant women. We were talking about
I think we're
screening in
talking,
medical settings.
at least when I was here earlier, we were talking about screening, but I think that the concern is that, the way that our system is set up, the screening, will have a chilling effect on what we're trying to do here. We're trying to get people resources that they need, and so that, if, people think that they're going to be penalized or, have, criminal, implications to their screening, it's gonna make it a lot less effective. But I agree that there should be universal screening, but we also need our system to be more fair and not biased if we're really gonna promote it, because then we're gonna have a really unintended consequences and it's gonna be not what we are trying to promote. But yes, I agree, we should have universal screening, but we also should not have any bias or disparities.
Right, so that's the chicken and the egg.
Can we
can't
leave our
have
magic
one.
wand and make that happen?
We have to trust.
So I trust
Physician.
Okay,
Sounds
next
correct.
task force.
Yes, I think.
That's right.
So you're saying you're gonna make a designated use close the meeting.
Yeah, I don't really know what that means, I'm just closing the meeting. Well, I will say on behalf of Meg, a big thank you to task force members, both in person and on the phone. It really has been a pleasure for me personally to hear lots of different viewpoints and have appreciated the way in which we've all respectfully shared some of our differing and similar opinions. I think it's exciting to see the recommendations starting to take shape. And I know that there's some things that we're kind of saying, well, we still need someone else to take a look at, but we've at least taken what was, this much bigger scope and refined it to say, these are what the priorities need to be. You need to look at these certain things. And that's really helpful, as the head of a state agency. It's very easy to get stuck in hearing from lots of different organizations that say, you need to do this, we need this, you have to do this, spend money on this. And it's very hard sometimes to prioritize all of those things. So having a task force like this to put their heads together from so many viewpoints and say, we all agree that, these 10 things are really the things that need to be prioritized, that's so helpful. So thank you for your time to travel here and your time spent in the meetings. I believe we're going to have at least one additional task force meeting where hopefully we'll be able to kind of look at the finalized recommendations and report make a vote on it. And I know DHS is gonna work to get that date set as soon as possible so that we can get everybody's calendar reserved. Okay, thank you, everybody. Thanks, everyone online.
Yeah, no problem. And it's all, we have our annual reports all online.
Oh.